Hello, everyone. Happy Friday. It is February 27th, 2026, and welcome back to the Deep Dive. I am well. We are so glad you're here.
Really glad to be here. And today we are talking about something that affects every single person in Canada, whether you've thought about it recently or not.
Yeah, exactly. Canada's health system. I mean, we are talking about the wait times, the hospital overcapacity, the workforce shortages that you see in the headlines. And the big question we really want to unpack today is, can immigration actually fix this?
It is the billion-dollar question right now.
It really is. But before we jump in, I just want to say a huge thank you for the engagement on our Pink Shirt Day deep dive earlier this week. The comments you left were just incredibly powerful.
Yeah, they really were. It is always amazing to see the community step up and share those personal stories.
Absolutely. And if you are enjoying what we are doing here, please take a second to comment, like, and share this video. It really helps more people join the conversation.
Because the whole point of this deep dive is to unpack complex issues in a way that is clear, real, and, actually interesting.
Right. So let's get into it. The healthcare system.
Yeah.
I think most people, when they hear healthcare, they just picture a hospital building, like the emergency room doors.
Which is such a common misconception. I mean, it makes sense. That is the most visible part. But the system is so much more than that. It is primary care, so your family doctors and nurse practitioners. It is acute hospital care, sure, but it is also long-term care.
Home care.
Right, home care, mental health services, diagnostics, public health. It is a massive chain of sectors.
And people move through that chain over their lifetime.
Exactly. And the magic word here, well, maybe not magic, but the crucial concept is patient flow. Think about how people move from one sector to another.
So if long-term care beds are full,
then the hospital patients who are ready to be discharged, they cannot move out. They have to stay in the hospital bed.
And if those hospital beds are full, the emergency departments start to crowd up because people cannot get admitted.
Right. And if you zoom out even further, if primary care access is weak, say people do not have a family doctor, more people just show up at the emergency room for things that could have been handled in a clinic.
It is basically traffic congestion, but, with stretchers.
That is exactly what it is. But the grim part of that analogy is that, unlike traffic, you cannot just build one more lane and hope for magic.
Because the lanes are made of people. Highly trained professionals.
Exactly. You cannot just pour concrete and solve a nursing shortage.
So that brings up a really big question about who is actually in charge of fixing this? Who controls the system?
Well, that is the classic Canadian constitutional puzzle. Under the Canada Health Act, the federal government provides funding, but they attach criteria to it. Things like universality and accessibility.
So the feds say, here is the money, but you have to meet these standards.
Right. But the provinces are the ones who control the daily operations. They manage the system. That means the system in Ontario looks very different from the system in PEI.
Different funding models, different staffing policies.
Different long-term care capacity. It is highly localized.
And here's where the immigration piece comes in, right? Because the federal government has a huge influence on the labor supply through immigration policy.
Yes. The feds control the borders and the visas, which means they influence how many new healthcare workers enter the country. But the provinces control the actual jobs and the licensing.
So you have this major disconnect. Immigration policy and health system performance are deeply connected, but they are driven by two different levels of government.
It is a recipe for friction. And that friction is turning into a full-blown crisis when you look at the workforce shortages.
Let's talk about the data, because the numbers really paint a picture here. We are looking at Statistics Canada reports from 2024, and the vacancy rates are, they're kind of staggering.
They are. What are the specific numbers you have there?
Okay, so in 2024, registered nurses had a 7% vacancy rate. Licensed practical nurses, LPNs, were at 12.8%, and personal support workers were at 6.7%.
And we need to clarify what a vacancy rate actually means in a hospital setting. It does not just mean there is a help wanted sign in the window.
Right. It's not like a retail store where the line at the register is just a bit longer.
No. In healthcare, a vacancy means operating rooms run slower. It means certain wards or beds simply cannot open because it is unsafe to have patients there without the mandated staff ratios.
Which directly increases wait times.
Exactly.
And then there is the primary care gap. The Canadian Institute for Health Information, CIHI, they reported that 5.7 million Canadian adults did not have a regular health provider in 2024.
Almost 6 million people.
That is just, it is wild to think about. If you do not have a doctor, you don't stop getting sick.
You do not, which pushes more people into the emergency departments, like we talked about earlier. And it leads to later diagnoses. People wait until something is unbearable before they seek help.
Which means higher complexity by the time they are seen.
Higher complexity and much higher costs for the system to treat them. It is incredibly inefficient.
Speaking of waiting until things are unbearable, let's look at the provincial wait times, because the experience you get really depends on your postal code.
The wait time lottery. What is the latest data showing?
According to the Fraser Institute's 2025 report, and just to be clear for everyone watching, this measures the median wait time from a GP referral to getting the actual treatment.
Right, so this is mostly elective specialist care.
Exactly. So in Ontario, the median wait is 19.2 weeks.
Which is substantial.
But look at New Brunswick, 60.9 weeks.
Over a year.
It is not a small gap. The Atlantic provinces generally show the longest waits. Prince Edward Island sits at 49.7 weeks.
And again, while this measures elective care and not the emergency department, it is a vital sign. It tells a very clear story about the overall capacity of the system.
And PEI is a perfect case study right now, because this isn't just abstract data. Literally yesterday, February 26th, 2026, Health PEI reported severe overcapacity at the Queen Elizabeth Hospital in Charlottetown.
Yeah, that was a major alert.
They had to set up temporary beds. And the phrase they used in the report was unconventional spaces.
Unconventional spaces. I mean, that is a very polite way of saying hallways, supply rooms, conference rooms. That is not just a busy Tuesday. That is structural pressure. The system is bending.
And going back to what we said earlier, a bed only counts if it is staffed. Putting a cot in a hallway does not magically create a nurse to monitor that patient.
No, it just stretches the existing nurses even thinner. And the CIHI data backs this up. They showed that overtime hours increased significantly between 2019 and 2023.
People are just working double shifts constantly.
Which signals massive strain on the workforce. It leads to burnout risk, which creates retention problems, which drives the vacancy rate right back up. It is a vicious cycle.
Okay, so that is the problem. It is massive. It is complicated. Let's pivot to the proposed solutions, specifically the immigration lever.
Right, because the federal government has recognized this and they are trying to act on it.
Yeah, back in December 2025, Immigration, Refugees, and Citizenship Canada, IRCC, they continued these category-based express entry draws specifically for health occupations.
This was a big announcement from Immigration Minister Lena Metlij-Diab. They're really trying to target the exact skills we are missing.
The details of this express entry are actually pretty interesting. They created a pathway specifically for physicians who already have 1 year of eligible Canadian work experience in the last 3 years.
Which makes total sense. You want to retain the talent that is already in the country and somewhat familiar with the system.
They also reserved 5,000 federal admission spaces specifically for provincial nominees in healthcare.
Giving the provinces a bit more power to pull in the specific people they need.
But the part that made me say wow out loud, they promised 14-day expedited work permits for nominated doctors. 14 days. For government paperwork, that is practically light speed.
It is incredibly fast. It shows that they recognize the absolute urgency of the situation. Getting them into the country is the easy part, though.
Wait, what do you mean?
Well, this is the real bottleneck. It is the catch-22 of our system. Getting into Canada is one thing. Being legally allowed to work in a hospital is entirely different.
The licensing.
Yes, it is a massive hurdle. Let's look at physicians first. If you arrive as an internationally trained doctor, your credentialing is overseen by the Medical Council of Canada.
So they have to verify your degree, make sure your medical school was legitimate.
Right. But then you usually have to go through a practice-ready assessment program, a PRA.
What does that involve?
It is typically a 12-week clinical evaluation. You work under supervision so they can evaluate your actual skills in a Canadian context.
That sounds reasonable. We want to make sure doctors are safe to practice.
It is absolutely necessary for patient safety. The problem is not the assessment itself. The problem is that there are incredibly limited seats in these PRA programs.
Because you need existing Canadian doctors to act as the supervisors.
Exactly. And as we just discussed, the existing Canadian doctors are completely burned out and working massive overtime. They do not have the time or the bandwidth to supervise new candidates.
So you have thousands of doctors coming into the country and a tiny funnel of assessment seats to actually get them licensed.
And if you decide to try and get a residency spot, instead, say you want to retrain or get into the Canadian system, that way you hit another wall, residency matching in Canada usually requires you to have permanent residency status.
Oh, wow. So you need PR to get to residency.
But to get the PR, you often need a stable job offer or Canadian experience.
It is a total catch-22.
It really is. And the nursing side is not much better. It is incredibly fragmented.
I was reading about this. For nurses, it involves the National Nursing Assessment Service.
Yes, the NNAS. They do the initial paperwork evaluation.
But then, after the NNAS does their thing, the nurse still has to go to the provincial body, right?
Yeah.
Like the College of Nurses of Ontario.
Exactly. So you are dealing with a national body and then a provincial body, and then often you have to take additional bridging courses or competency exams.
It just feels like endless delays.
And the takeaway here is that fragmentation creates delays. And every single delay in licensing is a patient waiting in an unconventional space in PEI.
Every delay is someone sitting in a waiting room for 15 hours.
Precisely. So when we ask, can immigration fix this? The answer is not on its own.
What is the missing piece then? How do we actually make this work?
Long-term success requires aligning the immigration selection process with the actual licensure capacity.
So do not invite 5,000 doctors if you only have 500 assessment seats.
Right. We have to scale up those supervised practice seats. We need to incentivize our current doctors and nurses to become mentors and assessors. And there is a big push for pan-Canadian licensure.
I saw the Canadian Medical Association is really advocating for that.
Yes. The idea that if you are a licensed doctor in Nova Scotia, you should be able to practice in Ontario or PEI without having to jump through a completely new set of provincial hoops.
That makes so much sense. We have a national crisis. We should have a national labor pool.
It would allow the system to shift resources to where the fires are burning the hottest.
So really, the metric we should be looking at is not just the total number of immigrants coming in.
No, the total number of arrivals is almost a distraction if they cannot work. The metric that truly matters is the time to first day in direct care.
Time to first day in direct care. How fast can we safely get a trained professional from the airport to the bedside?
Exactly. If that timeline is measured in years, the system will continue to break. If we can measure it in months, we might stand a chance.
Which leaves us with a pretty provocative thought to wrap up today.
Sure.
When you look at all these bottlenecks, the federal versus provincial divide, the fragmented colleges, the catch-22s, you have to wonder, is the system actively trying to solve these bottlenecks? Or is it simply just overwhelmed by its own complexity?
It is a very heavy question. Have we built a machine that is now too complicated to fix itself?
Something for all of you to chew on this weekend, because it really does affect us all. We want to know what you think we should tackle next in this space. Should we dive into the provincial nominee programs, or maybe do a full video just on the nursing pathways?
There is certainly enough material there for a deep dive.
Let us know in the comments. And please, share this video with someone who might find it interesting, especially if they work in the healthcare system. Keep the conversation going. Thanks so much for joining us today.
Take care, everyone.